Hello, my name is Gene Petrino with Survival Response, and welcome to our LinkedIn Live, where we discuss workplace violence and active shooter incidents. Today, we're going to be talking about the epidemic of workplace violence in healthcare. I'm lucky enough to have as my guest Ashley Moore and Rosa Dominguez Horsley. They're the hosts of the Nursing Post podcast, if I can say that straight. Their podcast is awesome. It covers pretty much everything nursing related. It's how I found them, and welcome, ladies.
Thank
you for
you.
having us. Thank you for the nice intro there. Appreciate it.
Oh, absolutely. No, I like I've told other people I found you guys through your nursing podcast because you're covering workplace violence, and you guys are very well versed on it. So I thought we'd have a great conversation about it today. But before we get into that, why don't you tell everyone a little bit about yourselves, how you met, and how you guys started the podcast and why? Either one of you.
Ashley and I worked together when we were working in pulmonary.
Okay.
I met, and we just clicked. We have very similar person, straight to the point, blunt, but say it with a little tact is everything. Delivery is everything.
So what nurses do?
Smile when we don't want to, and all those good things. And literally, I was the triage station taking phone calls, and I like, you know what? You can't make this stuff up. The craziness that goes on, and the phone calls you receive, and the day to day, you can't make this stuff up. And I was like, about this, we need to do something because this is getting out of control. What nursing is supposed to be.
Oh yeah.
And Ashley was like, we've been doing it ever since.
No, that's great.
I think we just realized that there needed to be a lot more education. Everybody can kind of understand. And I think we take for granted, even nurses have a specialty that you work in. So if you've worked cardiac for the last 20 years, if you see they're I'm sure that they could make do, but it's a learn that. And nurses, we are adaptable, but we do kind of in a way subspecial, and being able to just kind of cover a nice genre diseases and things that nurses need to be aware of. It meant a lot to Rose, started off with like a teaching background. So that's kind of something. And then I just have a knack and a drive to really the ones that have trouble with understanding and getting the best care that they possibly.
No, that's great. And it's funny because I think you're right. There's a lot of people in service-based industries like law enforcement or nursing. We do take for granted the knowledge that we have, and when new people come into the field, it's not always passed down the best, depending on the organization you're at. So it's nice to get that bigger perspective, like what you're doing. So that's great. That's really good. So there's a lot going on with workplace violence in nursing. I mean, we could probably talk for hours and hours, which we're not going to, but want to hit on a few things. So, what is being that you have your own podcast, you're probably hearing from I can't even imagine the amount of people in the field that have talked to you about it. What are some of the takeaways that you find? Well, first of all, it's obvious it's going on because 75% of all workplace violence occurs in healthcare. So there's no disputing that it actually is happening. It's definitely happening. Do you guys think it's underreported? Because there's a lot of talk about it being underreported.
Absolutely.
So that's one thing I want to talk about. Why do you think that is? I think I know, but why?
I think it's a one, retaliation. A lot of this is a open door policy. We support back. You're of the utmost importance. We appreciate you. retaliation, it does exist, even if someone is going to tell you it doesn't. It does. Whistleblowers end up being terminated. They're targeted. If it's not by, maybe by their coworkers. So I think that's probably the why things don't go reported. I think too, nurses have desensitized to it. We hear so often that we are part of our job. We heard that a lot even through the pandemic. We knew what we were, but that is not actually what we signed up for. We didn't sign up for physical assault and battery, and we definitely did not sign up for the pandemic. And I think like law enforcement or the military is its own terminology. It has its own sets of rules, and it's kind of has its own language. And I think that is some of the issue in and of it. I feel like a lot of people just don't understand. A lot of people that are sitting high up making the decisions on nurses, so they have no experience when they make these decisions, trickle it down to nurses and aides and etc. So there's that as well that we're looking at.
Yeah, that's good points. And I flashed back when you said something, because when I started in law enforcement, my first couple of months, I asked for a bulletproof vest because we didn't really have them. And they said, well, you get paid to get shot. And I'm like, no, that's not what I get paid for. I'm not doing
that in the fine print.
Yeah.
Let me read.
So when you said it's part of your job, like, no, that's not what your job is. So I had a little flashback to that. And that wasn't the actual culture of where I worked. It was just the person that I spoke to was probably not the right person. And they were just about retired at that point. So, but I just laughed when you said, I just flashed right back to that point, because I'm like, no one wants to get hit or hurt at work. That's not the purpose of it. You're there to do a job. And so, well, you said a lot. You said so much right there. So retaliation. No, it's great. No, it's great. So, yeah, well, that's why I said we could talk. We could really have a long conversation. So retaliation is a big problem. Do you find that when an incident happens, that when it's being investigated, that there is pressure to not report this or take it farther?
It's funny.
I know the answer.
Because Rosa and I were having a conversation. Maybe it was yesterday. I don't know. Again, there was an article that I was reading about from. It is from actually the American Association of Critical Care Nursing, and it was about work to do. And this was out last year, and it talked about there's a big lack of reporting, and one of those things is a lot of nurses say, report it, nothing's going to be done. And that's exactly, I know that's like, if there's somebody coming in and they're drunk or the kind of substance and they're violent, they're going to be like, oh, well, that wasn't them. They were under the influence. Those are all the things that I know ER nurses probably hear all day, every day. And every time they were physically assaulted, that's probably they would spend a portion of each shift doing. I was like, well, I wonder how true that is. And in that article, it actually 6% of the reports that were filed, nothing was. So I was like, so we're not crazy. How about that? Huge connection, because
the other issue is
California, but I'm sure it's going to be in the United States.
Yeah.
One of the issues, to piggyback Ashley, is that there really isn't any formal. So if you work in a hospital, that's fine. You look like you're supposed to. Then what what does it do? Does it lay on HR's desk? Who picks it up? Who is responsible for initiating or further investigating? There, if you work in assisted living, which I have spent like about 5, you don't even have a human resources person.
Yeah. You know, it's
Difficult.
it's not, yeah, and you guys aren't the only industry where I see this happening. Um, I feel like that people don't know what their rights are as far as filing charges and things like that, because nobody can tell you not to file charges. No, if you're working in a position, they can't tell you you can't call the police. You can't file criminal charges. If you have every right to do it. And that's a personal choice. It shouldn't be up to an administrator or any supervisor or anything like that. It has to be a personal choice if you want to go through the process. Um, and you know, I can. There are instances where I think where I'm sure I've said, you know, you should just let this go. It's not worth it. Not that it wasn't a crime that occurred. Not that it wasn't that I wasn't concerned that the person went through something. It's that understanding the legal side of it, the system of how it works, nothing will happen. You'll end up wasting all this time and energy for nothing. So I wonder if if there are some of those instances where they come in, because I think you'll all, well, maybe you won't. There are some people that will say everything is workplace violence, and some people will say nothing. Like, in other words, someone walked by you and bumped into you. Oh my God, I was just assaulted. No, they didn't mean to bump into you. It was an accident. Some people, you're laughing. I see Rose, I'm seeing you smiling. This happened to you.
I know if the mask's not available anymore, I'm not very good at hiding
But you know what I'm saying? Like, there are times when someone, you know, where sometimes something happens that wasn't necessarily intentional, and there are some times that it's absolutely intentional. And I think that can cloud from a supervisory standpoint. When do you know, how do you try to guide an employee?
Mhm.
And the problem is there's too much ambiguity to that, which is why, you know, you've got these new laws coming out, hopefully, that should try to sort of normalize how a process is set up. So, you know, we talked about this before we went on air, and I have to read it because I'll get it all messed up. So HR 1195, that's the House bill number. In the Senate, it's S 4182. It's the Workplace Violence Prevention for Healthcare and Social Services Workers Act. Could they make it any longer? But it's a pretty
No, it's a
comprehensive.
generic drug.
Yeah. I mean, it's funny. I read the whole thing multiple times, and it's got a lot of good stuff in there. But sometimes when I'm reading these things, I'm thinking, why is this not already being done?
There aren't
And I think
nurses at the top.
you just took I was just going to say, Rosie, you said earlier that the people at the top really don't have the experience. And I think that falls true for a lot of, not just nursing. I think any industry you'll find that there are people that get into a position where they're not really experienced for that position. We've had in Florida, we've had sheriffs, which is an elected position with zero um, law enforcement background. So they were like an attorney. They never really did any law enforcement, and they really had a hard time doing their job because they couldn't understand the process. They don't understand what it's like to be on the bottom and working your way through these challenges that everyone has, just like in nursing. And I think that's pretty important. Do you find that most hospitals or most people that you talk to, the CEOs or the administrators, have little experience? Is that kind of the way you guys feel? Or yeah.
I think some of the administrators, you know, typically where we're at in the hospital, the administrators are physicians, but we worked, of course, somewhat in a clinical setting, whether it's by bedside. But then once they move into that role, I think you very quickly can lose of bedside and, you know, what needs to be done. To have like committees that you trust and you actually listen to. You have, you know, committees that are supposed to be making decisions about nurses, some people, but having a nurse practitioner who's not working bedside count
Mhm.
as your nurse is not is not comparable. I mean, that's not comparable. I'm not a bedside nurse. They probably did. More than likely, they did it at some point to be. However, when you've been removed from that role for quite a bit, then making decisions about what's going to happen for bedside nurses, that doesn't make sense. A lot of places, they just require a small percentage of their committees to have nurses on them, and then usually that RN, and then the rest are some type of provider, like a nurse practitioner. And I'm like, a nurse, because it's a nurse practitioner. And I'm like, well, no,
the word's there, so
not an apples to apples. And at that point, because nobody really has a good idea of what's going on, and nurse is one RN, he's probably sitting there going, no, that's not right, you're all wrong. And they're all looking at her like she's crazy.
yeah.
And then nothing gets done. And you go, well, I don't know why. And I'm like, no, you have like a nurse, and then the rest of providers.
It has to be more than one.
Yeah.
More than one.
I mean, it should be more of bedside nurses.
Okay. Yeah. I mean, I was just thinking, I always try to figure out, have I experienced something like that? And I have, honestly, when I was working and I went through promotions, you do forget. You do forget things. You really do. And then you go back to the bottom, and you're looking around, you're going, oh my God, what are these guys going through? Oh my God. And you forget about it. So that might just be something that needs to be, that would probably be a good strategy for administrators to maybe start going in and contacting the people at the bottom. I hate to say the bottom, but you know what I'm saying. The people that are not in administration, go back to the floors, see what they're really going through, and start to understand what they need. Because I think there's value there, and and that doesn't cost anything. That doesn't cost anything to go see what people are doing, and it's really about leadership, right? I mean, it's about understanding what your people are doing.
Yeah.
Well, yeah. I mean, so you just hit the next big thing is that I've always said is that a good leader is very humble and isn't afraid to ask for help and isn't afraid to let the people below them make the decisions, as long as it's within the parameters of what the mission and the goal is of what they're looking for. Here's what I'm looking for, carry it out, and that's it.
My previous place of employment, I was a director of nursing, but I humbled myself. You're not going to get any respect from anyone if you're not willing to be in the trenches, so to speak.
Yeah.
So if there was regardless, I would go in on third shift and provide care, and all of that. I've had employees say to me, what are you doing here? And I'm like, I had to start exactly where you were, to get to exactly where I am. Literally, they looked at me and said, none of our directors of nursing have done that.
Yeah.
Well, then how do they know what's broken? Who are they going to go to help correct it?
Yeah. Well, they're looking at all the financials. They're looking at reports. They're looking at they're looking at everything but the people. And I'm sort of on this mission that healthcare needs to stop looking at patient care as the priority and looking at employee care first. Because if you follow the way it all happens, if the employees aren't happy, they're not going to do their job right. They're going to be miserable. They're going to do the bare minimum. They're going to, they're not going to pay attention, which means that there's going to be patient errors, right? The accidents are going to happen because they're overworked, understaffed. They're not paying attention. They're miserable. They don't care. That creates all kinds of problems. And that's where it all starts to snowball, right? You end up having, readmissions. You have all these other issues that start to happen. And then guess what? You have longer wait times. So who's going to get angry? You're going to get the patients and you get the people that are waiting there. And they're angry that they have to wait 45 minutes. God, I can't even imagine a place that's 45 minutes.
8
It's got to be like
hours.
2 or 3 hours at least. But,
8
you're waiting
hours.
hours and hours to get in, and now you're already miserable. That, that's just it all kind of creates that problem. So I think staffing is a huge issue that if that could be resolved, um,
It's not
that would be a big part of it.
impossible.
No, it's not. It's actually
California
very
has those in place. California two nurse ratios, and it works for them.
Yeah.
And yes, during the pandemic, some of those altered, but they have it and it works for them.
Mm-hmm.
So for that system won't work, it hasn't been proven. Say that to the nurses that are working in California and ask them how they feel. Has it worked for them? And I'm almost 1,000% will say they would rather work there than work somewhere else in which there isn't to nurse ratio. I can tell you here, working in a system, easily have at least 135 residents underneath me, nurse. That's not safe.
No, it's not safe at all.
That's not safe.
Horrible.
It's not. And
No.
I feel like if you fix the ratio, it will make things better. However, it's not going to take things away. When we marched back in May, we marched on 4 issues. And of course, the biggest 2 were ratios. The third, was like money. That's always going to be an issue. Money in these types of fields of work. But those 2 right a lot. And I'm not talking about pressing charges against someone who has demand, who has mental health issues. But let me tell you, the system is broken, and Ashley can jump in at any time. The emergency room, your primary care provider. It is not your mental health provider. But as a country, that's exactly what the ER has turned into. You get wait time in our local emergency room because it's being used as those issues of hypertension, cold, and COVID right now can be handled through your primary care. But then on the second is not being addressed nationally, worldwide, in any form of fashion. If you need a hold, you have to go to the emergency. I don't know in Florida where you live, but I can tell you here in our emergency room, there is not that sits in the emergency room with the other EDs for a medicine. There's just not.
Yeah. And
they're not staffed for those types of patients. And there's just not enough centers, period. And that suffer mental health, substance abuse issues. They where do they go? They go to the emergency room. Where does most workplace violence and health? The emergency room.
Of course.
So you're already short-staffed, and then you have inappropriate health care taking place there.
Yeah.
No, well,
you're right.
Curious. With your background being in law enforcement, and I'm sure most ER nurses who've worked in the ER probably you have a patient that comes in that's having, some type of psychiatric, they're under the influence of something and they are physically assaulting you, taking their medication or ingesting something that they weren't supposed to do. And, well, they can't help it. Then part of me is like, well, they also made a choice to not their medication. So from a law enforcement perspective, that's not law enforcement arrest those people and they are charged with whatever. Yep. So why stop that at the door of a hospital? We're there to help you, yes, but for your actions, irregardless. I mean, maybe minus a demented patient does not know what's going on, and nurses aren't worried about dementia. You have a combative demented patient, you need 2 nurses in that room with the patient. But again, there's not enough staff for that.
Yeah, and that's what I'm saying is that if you solve the staffing issues, you'll have the ability to have 2 people in easily, when those patients come in that have that problem. But yeah, it's the same thing down here in Florida. The most, I shouldn't say the most, but a large amount of the workplace violence in the emergency rooms are either some kind of intoxication, whether it's alcohol or drugs, and it's homeless, where there's usually mental illness of some kind, or a combination of
Mhm.
those. And so that's
Yeah.
what they're really dealing with. And from a law enforcement standpoint, when you involuntarily take someone to, for their well-being, we have to take them to the hospital, get cleared. And we used to be able to have one facility that we would take them to, but things have changed and all these different rules start applying, and then you can't go there anymore. So you got to go to the hospitals that are not prepared to deal with, you know, before, even if staffing was great, they weren't ready to deal with the amount of patients that are being brought in
Yeah.
under those circumstances. So it's a challenge, and it's sad because, you know, there's bigger social issues here, right? There's drug abuse, mental illness, and how do you treat them, and that's a whole nother show of how to deal with that. But it's
Mhm.
amazing how much it starts to impact everything,
Absolutely.
and
Mhm.
it's unfair because the fallout from it is you're losing nurses that got into the job for all the reasons that anyone in these professions do. I got in because I wanted to help people. You guys got in because you want to help people. It was all about that. It was all about these idealistic dreams of, making our communities better, safer, helping people that are in need. And when you kind of get pushed down so hard, you just say, I'm done. And do you find that a lot of the nurses that are leaving, are they leaving for other areas? Are they going more towards a travel nurse kind of thing, or are they just leaving altogether? What's been your experience of who you guys are talking to?
I think it's in a combination. Nurses are
Yeah.
traveling. I think those are the nurses who still like nursing, but they want the compensation. Nurses are branching out and doing their own thing within healthcare,
Mhm.
Still get the impact that they want to still, feel that need to help on their own terms in ways that they've learned within their like area of expertise.
Mhm.
And I know that I've seen branch out and start their own businesses and said, no, I'm not doing this. Like, we're adaptive, that we work our butts off. We can communicate well, and it sets us up to be able
Yeah.
to say, some
Problem solving skills. Most nurses,
Yeah.
can't speak for
yeah.
everybody, but so you're going to see a lot more what we call nursepreneurs that are going to start taking control, basically. And I think you're going to see a lot more independent contractors and studies, because then they get to make the decisions. They get to have the ball. So if these laws don't pass, that is what I see.
Do you think, all right, let me ask you this, because this is how I've felt, and still feel to this day feel, and I think I can relate it to a lot of different perspectives, but most people are more inclined to stay at a place where they feel safe, where they're supported, things like that. Even if they got a better job offer for more money, they're more likely to
Absolutely.
stay and give up those extra perks if
Mhm.
they felt like they had the support, if they felt like they were, you aren't listen. It's never going to be 100% safe in nursing. There's no way. It's just because you're dealing with humans. Same with law enforcement. You're dealing with unpredictability. You don't know when someone's in total, crisis. You don't know their circumstances when you first come upon them. So you don't know, and they could just lash out, and that happens. Um, but I just have always believed that people stay because of the environment, not because of the benefits of the pay or anything like that. You guys you're both nodding yes, so I'm assuming you agree with that. Because I think that's one of the
I
big one of the big things that the CEOs are saying is that they're bleeding
absolutely.
out they're bleeding out because of all these nursing, all these people that we have to contract out with. And my response is, well, then why don't you create an environment where they don't want to leave? Why don't you reward the people that are staying there? Instead of offering sign-on bonuses. I just saw something the other day on TikTok. Yes, I watch TikTok. Um,
You're not alone.
I know. I believe me, I'm not. But it was two nurses, and they're like, the one was sitting next to the other one, and she says, "This is the look on my face when the person next to me is making 3 times what I'm making doing the same job." I'm like, but how are you going to make the, and not that they're mad at that person, they're mad at the situation, they're mad at that environment that's allowed to happen.
Absolutely.
And that's, like I said, it all comes back to staffing. It all comes back to taking care of your staff, take care of your nurses, the techs, everyone,
And
really, even doctors are leaving. There's doctors that are they're leaving for the same reasons. So
oh
it's not just a nursing issue. I think originally it's been looked at. I think nurses have been blamed for a lot of things over the years. And now doctors are leaving because they're like, this is not what I signed up for. So
This
fix
is the
that.
highest turnover care that I have seen through the duration of my nursing career. Or you're right, it used to be, oh, nurses have such a high turnover, but through the pandemic and even now, this is the highest that I have ever seen physician turnover, because it's not just physicians. We're talking about physician assistants, nurse practitioners, professionals, and healthcare that go through the same thing. Maybe not on an everyday do the same thing. And the thing about it is that we have to normalize that this is not to any nurse or any healthcare worker actually and ask them to tell. Now, either they're going to tell you their story, or they're going to tell you a story that they heard from their they're verbally assaulted or physically battered. That's how much it is, and that's not okay.
Yeah.
It's not okay. And the risk of everything back in the day was about intelligence, your IQ, your degree had behind your name. We're not tailoring to that generation anymore. We are now in a generation moving forward where intelligence. So your person that's leading, it's nice on everything looks good on paper, but if you don't have those skill sets to make ends, to build rapport, to have your open door policy, you say you're not going to retain staff. And it doesn't matter how much you pay them ever. Don't have somebody that's going to treat you as an individual and as a person, and their belt of I don't know, Lay's potato chips, just one right after the other, after that rotating door. And your budget is so much more expensive new people than it is retaining the ones that you have. And that's just a fact.
Yeah, no, I agree with you. It seems like such obvious answers to me. I mean, it really, it is more complex. There is a lot more that goes into it, but if I think that there's so many times that when we face a problem, right? We look at it through like, this is a big issue, we got to fix this big problem. And so you're looking for big solutions, and you start throwing money at stuff because, oh, well, we need to do this. We need nursing shortage. All right, we need to find more nurses. Oh, the traveling nurses, let's throw money at them. Let's keep getting the, well, you're just throwing good money after bad. Yeah, you're filling the void, but you're not fixing the problem. And so in the long run, you end up costing so much money that you now, as now I'm coming from an administrative side of things, you're now losing your profitability. Your profitability means that you can't go towards looking at new stuff that's in the future, like all the tech that's out there, especially all the AI stuff, as far, diagnosing. There's so much really cool stuff out there, but hospitals can't afford to really even look at anything like that right now because they're busy trying to deal with the problem that was largely created by them, which is the shortage in staffing. So, and I agree with you about how, you look at someone's background, you look at all these letters after their name, and I've got these degrees, and if you don't have the ability to talk to somebody, um, and think, have that critical thinking skills to be able to look at a problem and resolve it, it's going to be a problem. So yeah, no, that's interesting though.
Yeah, but
Go ahead.
It all plays into each other.
It does. Everything is connected. It really is all connected. But like I said, when I started looking at this, I connect everything all right back to the staff. It all comes back to the staffing. If you focus on fixing that, that will start to untangle the other issues that are coming up. It's going to fix the profitability. You're not going to have to pay for all these people, pay 3 times the salary to have somebody come in for a short period of time. You're going to be able to retain people. And when you retain people, people that like where they work, they do a better job. They're more productive. They're more efficient. There's studies, so many studies that are done on leadership and things. And they talk about, employees that have a voice they feel free that they can go to their boss and say, hey, I was thinking, what about this? Can we try this? And they might say, no, we can't. We've tried that, and here's why. But if you want to look at another avenue, try. It's that open communication, that dialogue that I think is missing a lot of times, especially when you get to a larger organizations. You start to lose that. But that's a leadership that's a leadership issue that can easily be addressed. But it just seems like there's a lot of things that can be that can be done to turn the wheel around on this, because it's going to be bad, especially if this law goes through. I was just reading something about for the Workplace Violence Prevention, Healthcare, Social Services Workers Act. So the Congressional Budget Office estimated that for the first 24 months, it's going to cost $1.8 billion for these hospitals and the private hospitals to get up to speed on everything. $1.8 billion. If you aren't looking at these numbers, if you're not administratively saying, gosh, this is actually, if this is going to go into effect, it's going to be, just another thing to cripple us if we don't get ahead of this now. Do you guys see?
Start working on staffing. If they start working on staffing, drop that billions of dollars right down.
Yes. And it's funny because if you read the whole, I don't recommend it, but if you read the whole bill, it talks about it in all these bills that are out there right now. They talk about it. They talk about how the savings from this comes in the form of reducing absenteeism and turnover rates and things like that. So I'm not a fan of government regulation, but I'm also a fan of when an industry as a whole can't get something together and it gets to this level, that the government's going to step in. And I'm like, well, you kind of did it to yourself. I mean, I can tell you that from law enforcement, we did it to ourselves. We have forfeiture laws, and they are a great tool for law enforcement. And our agency was awesome at it. We were very fair about it. We didn't just go take people's stuff, but we took them when we needed to. And because that's how you hurt the drug deals. You hurt them by taking their money or their cars, whatever. But it was being abused. And I had no idea. I was so clueless as to it. I'm like, why is the government changing our laws now? Because they made it a lot harder. And then I started reading the stories. I'm like, yeah, we did this to ourselves. We deserve, yeah. And they changed it and they made it a little harder to do. But I don't blame it. After hearing the stories and seeing the evidence mound up, you're like, yeah, we did this to ourselves. And I think that's sort of where healthcare is right now, is that some of these problems, you can't control everything, but some of the problems could have been controlled a little bit better. And I think the methodology of running a hospital, of efficiency and lean and all that kind of stuff, really backfired. I think it's costing them a lot more than they expected it to.
The idea of having a lean team is parts, and you work in a factory, but we work with people. There's a big difference there. And some people don't tend to see that as a big difference. I'm like, oh, what takes so long to get the patient out of the waiting room? Well, when they have to stop and go pee, and it's because they're in a walker, but they want to be independent, but they should be in a wheelchair because they're a fall risk. Variability there. And so thinking about, the cost to implement something like this, and the reason I have zero sympathy for that is because, like you had said at the beginning of this, 75% of all workplace violence, that is pretty significant. But that is not new for years.
Mm-hmm.
And so we've known about this as an issue. Now is we're just fed up. And, the pandemic, those numbers, and made it even worse. And a lot of the physicians, I don't think, the nurses were taking the brunt of it. The nurses, the techs, the aides, the allied before it even got to the doctor. And there is something to be said for, that you first meet with kind of gets the worst of it. And then by the time they get to the doctor, settle down, or they're not going to take it out on the doctor. It's kind of the first person, receptionist, a hug, a triage nurse, whatever. That person, the worst spot. And then it's just going to escalate after that. And then it gets to a point where it goes up. And if we've known that this is an issue, then that in the United States has that opportunity to go ahead and start implementing all these things, mitigate the risk of workplace violence, but yet they haven't done that.
Mm-hmm.
Let them cough up the money.
Yeah. Well, it's, yeah, I can't disagree with you. Yeah. I mean, listen, I think you really made a great point though, that because again, and it really, this is how I always say law enforcement and nursing is so like in line, and healthcare is so in line with each other, because it's the same thing. It shouldn't be about the money. It should be about helping the person or the situation. But the money always gets pulled into it, and it has to. I understand that money does play into it. My boss used to say to me, he's like, "It's not about the money, but it's about the money." I'm like, I get it, because you still have to have the money to fund, and you have to still, pay for everything. But sometimes that gets clouded, and you put too much focus on the wrong side of it, and you end up, thinking why we don't need it. You don't really need that. We get rid of that, and you start slimming down everything, and it just creates more of the problem that you're trying to fix. And I think again, that's where Rosa, we were saying, the people at the top lose perspective of that. The higher up they go, the longer they're there, they forget what everyone goes through down at different areas, especially where they're making these big decisions that impact everything below them, and they don't always understand how that's going to happen. So yeah, no, that's pretty interesting.
This is
what else did I
not a topic that's going to, with this bill just being passed, we've been like way before the pandemic. Things just got really ugly, and unfortunately people became during the pandemic, that heightened sense of paranoia, the heightened sense of fear, knowing what's coming, that just pushed everything, I think, over the cliff. Happen overnight. Change doesn't happen overnight. But I can tell you for sure, in agency nurses, the amount of wage that you're paying, that back into your current staff and hire the appropriate, then I can assure you that you will see a decreased amount of workplace violence, because it's not just health care and law enforcement. So they're hard. We all say, some of us, we would never be nurses, but I don't think I would ever be a social worker. They probably deal with a lot more verbal assault than
of course
we do. And now we get called all sorts of stuff. I don't care. You can call me what you want. I've probably been called worse. But on people, it does take it to a next level. But the more hands that you have on your deck, that makes it easier for that nurse to take time to try to calm said person down before it escalates the point, punching people and stabbing nurses and all the stuff that you see going on now locally and recently. And all, but it boils down to,
in a way, that, because I was thinking, call me whatever you want. It's like that's still verbal assault and threatening. But
it is.
I'm like, yeah, we're good. Like, that's a problem. Like, this is what nursing has bred to be like. Oh, they call, you just end up, you just quote it in the chart and kind of laugh, finish out your quotes, and you go on about your day. And, ultimately, it's not, have gotten so accustomed to being, verbally just put through the ringer.
Yeah.
Whether it's all different things. It's not a bed and breakfast. It's a hospital. We're a clinic. There's a big difference. And gotten so used to it as nursing that it's kind of like, if we can stop it at the clinical, then we count that as a win.
Yeah. Yeah. So, God, I'm telling you, we could talk for hours on this. So, you had talked. We're kind of broaching the training aspect now. So, I want to just briefly cover that. We don't have much time left, but do you find, because I totally agree with what you guys are saying when it comes to training. So now there's always, the big thing is de-escalation training, blah blah blah. Okay, which is fine. It's something that's needed. Do you find that when you guys are put into a training situation where you're going to be trained on, let's say, de-escalation or whatever, that it is seen as more of, is the hospital saying, we'll just check off a box that they had the training? Is it really taken seriously? No.
It's a PowerPoint presentation that everybody has to sign and say that they attended. You may or that presentation.
Yeah.
You may not.
This is what you could have said instead of, yeah, we all know that. Like, instead of saying, most nurses aren't going to yell at a patient that, I don't know what you want me to do about it, and walk away. Now, there are nurses who do that. Body is meant to be a nurse that is a nurse. However, if we're waiting on order, we have to contact the doctor, do whatever, and we tell that to the patient all because they're in pain and feel like they're not getting proper treatment. What we need is and I really don't think that I've ever been given proper for, hey, this is how you need to deal with somebody. It's kind of like, okay, pick up pages the entire office. It's like, first off, I'm probably not in that situation because hopefully it happens few and far between where I have the page the entire office. And then two, if you're in a hospital room, getting assaulted, I don't really have the ability to say, oh, can you call for help before you do anything else?
We don't have enough hands-on training. We don't, period. I was fortunate enough to where I could further my education. I'm a certified dementia practitioner, speaks and things to de-escalate people that have, mental health issues. I was fortunate enough where I was able to take a self-defense class. They don't, I had to pay out of pocket for all of that stuff. You'll take the time, you'll educate yourself, and you'll do that, and you'll invest in you because you're investing in you for your patient and their longevity. But that's not something generally that you're to offer you. They're not going to offer you hands-on de-escalation. They're not going to show you or how to maneuver disarming somebody. Will show you that. That's not the training and education that we receive. It should be more than once a year, and I feel it should be for each and every single employee that walks through the door, orientation package.
So yeah, they the bill actually talks about that. It talks about having annual in-person, and then after that it's virtual, but live virtual. So in other words, like this, not just a recorded video that you watch. So I think that's a valuable thing, is that the value in training is being put into this bill because it's something that needs to be put in, it needs to have a place for there, because so many times, and I can tell you that places that we've taught active shooter training, some places are, you can see that they just want to check off a box saying that we had it.
Yeah.
Yeah, everyone got it. Sign off that you did it. And
Yep.
when you don't take it seriously, when an employer doesn't take training seriously, especially with workplace violence, the employees don't take it seriously, which means that it's going to impact when something happens. They're not going to know how to respond. And we see that with training for active shooter, with run, hide, fight. People don't know how to respond to it when they're in it, because they're like, well, we had training, but wasn't paying it. I mean, it wasn't going to happen here. That's how our boss looked at it. Well, it happened. And the likelihood is very low for everyone, everyone except for healthcare. It's low statistically to happen to you. But if it's not taken seriously, if it's looked at something that's just of like, we just got to sign off on this, no big deal, you're going to have a big problem. And I think that's one of the areas, definitely with nursing, and it's hard because I feel like just about every profession is being pushed into having to deal with more than what they originally were designed to deal with. Like de-escalation for you guys. Rosa, you talked about, disarming people. I mean, should you have to worry about that as a nurse? Should teachers have to worry about, should we carry a gun as as a teacher, all that kind of stuff? Should we be doing? No. I mean, we kind of get away from that, but I don't think that I think it's just part of the reality that we're in now, that we're all going to have to take on a little bit extra. But if that's the case, I think everyone's okay with it. At least I would be okay with it if I had the support of the administration behind me. Right? Does that make sense?
I need staffing support. I need administrative support. I need support. There's so much support that we need. Like I said, it always comes back to staffing. If you have the appropriate unit and on a floor, then you have time to talk down that person who is at your. But if you are a nurse and you have 10 patients and half of them are in pain, 2 are borderline getting ready to flatline, you don't have to sit there and de-escalate anything or talk anybody down. You don't have time with your patient. And we nurses spend more time with patients, and I think people seem to forget that a lot. Just like Ashley said, where that doctor comes in, we get everything. We get it all.
Yep, I agree. All right. Well, it looks like we're
about
out of time. Oh, go ahead. Sorry. I was just going to say if there's anything else you want to add.
I was just going to say the charge nurse in a lot of those situations, I think was at first the thought process of, okay, the charge nurse would then jump. But again, it's so short staffed that most charge nurses are also taking now their own
floor staff
to make sure that it is running. So it doesn't work that way.
Yeah, it's crazy. It is absolutely crazy. So I want to thank you guys. It's been good. I mean, like beyond good. This was really what I was hoping we would talk about. I think, first of all, thank you for what you guys do. It's another one of those professions where, you don't get the recognition that you should, given the amount of work that you go through and the amount of stuff that you put yourself through. No one realizes that, at all the tragedy you end up seeing throughout your career, it plays a toll on you personally, on your family. It changes, who you really were when you became a nurse or go into a field. You're not that same person anymore. So it really does have a deep impact on your life, and people don't realize the value and the sacrifice that you guys are doing. So I do appreciate it. Where can they find you or listen to you guys for your podcast?
Well, our podcast can be found on any podcast platform available everywhere. And then you can also find us. Our website also has everything on it, and that's the nursing.
Okay. Yeah, I've got it on the bottom of the screen there. Well, I do appreciate it again. Is there anything that we didn't talk about that you would like to say?
No, I think we covered it pretty well.
Just be a decent, kind human being or coming to see us that is probably not on your best day. So just give us a little, for nurses, you know, but also remember the reason why you became a nurse. You know, it's hard to smile. It's just that smile that helps your patient to calm down, relax, feel safe and secure. It's a two-way street. Can't blame everything on corporate America. You can't blame everything. So just make sure that you're reflecting and you're being a kind human being.
Absolutely right. All right. Well, I appreciate you guys. Again, I encourage you to check out their podcast. It's really good. I've listened to a few of I'm not even nursing, but I listened to a few of the episodes because it's interesting to me. It's interesting, and I like to hear that. I like to hear the experiences of other people. I think that, you know, when you start to get insight into what other people do and the challenges that they face, you'll find that we probably all share some of those same challenges in our own way. And it brings a better understanding, and it will maybe give you a different perspective when you're in a situation where you're dealing with someone in healthcare that you think maybe they're going through a lot today, and I should maybe be a little more patient if I have to wait a few hours to get into to see a doctor or whatever. But thank you guys so much for being here. I really, really appreciate it.
Thank you for having us. We've enjoyed.
Excellent. Okay. Bye, guys.
Bye.